Hello everyone and welcome back to my channel. So we have started the preparation for obstetrics subject and we have discussed our first two topics, that is the preterm labor and premature rupture of membrane. In this video we will be discussing the antenatal care and the follow-up visits and the fetal well-being. So started our today's video. We are having the first topic is antenatal care. For antenatal care we are having a scenario that there is a PG 8 weeks pregnant attends a antenatal clinic for advice. So define the booking clinics, important investigations done during booking clinic, and briefly describe schedule for the follow-up visits during antenatal period, and decide for NVD or C-section. What are the causes? Another scenario is that there is a G3B2 10 weeks and she is having previous two NVDs and came to antenatal clinic for booking. So note on antenatal care. And another scenario is that there is a PG with 16 weeks pregnancy and came for antenatal checkup to OPD. So what is the management options and what is the follow-up till 12 weeks? So for these topics, these questions, we will study this topic in detail. What is antenatal care? The care provided to the woman from the time of conception till the onset of labor in order to get optimized outcome for the baby and the mother. Okay, so the aims for antenatal care are to prevent, detect, and manage those factors that adversely affect the health of mother and baby, to provide advice, reassurance, education, and support for the woman and her family, to deal with minor ailments of the pregnancy, and to provide general health screening. Now, booking visits are done in the antenatal care, and these are the first risk assessment is usually made at the booking visit. The confirmation of pregnancy is done, which shows the symptoms of pregnancy, and positive urinary and serum pregnancy test is done, and the dating pregnancy, that is usually LMP by Nagel's rule and using dating scan. So the first of all, through the first visit, pregnancy is confirmed through the symptoms of the pregnancy and through positive urinary test of beta HCG, and the dating pregnancy and using LMP by Nagel's rule and using dating scan. Then the next visit is the booking history, and then the booking examination, and then the booking investigations are done, which are CBC, blood group and red cell antibody, rubella, hepatitis B, HIV, syphilis, and hemoglobin studies, and gestational diabetes mellitus and fetal abnormalities are checked through booking visits. Okay, so first of all, the pregnancy is confirmed when the patient feels the symptoms like she is having the positive urinary test of beta HCG, and then using the dating scan she can suspect for pregnancy, and then it is confirmed. Then after the confirmation of pregnancy, the next one is the booking history, which is biodata and detailed event of pregnancy and past obstetrical history, past gynecological history, the past medical and surgical history, the family history, and the social history. Now, booking examinations are done, which are accurate measurement of the PP, the abdominal examination, the size of uterus, the recognition of any abdominal scars indicative of previous surgery, the measurement of height and weight for calculation of BMI, urine examination, and pelvic examination of the genital infection. These are done on the booking examination. Now, the booking investigations are FBC, that is, it is for screening anemia and thrombocytopenia. Most common anemia is iron deficiency anemia. HB ranges from 10 to 12 gram per dl due to hemodilution as compared to 12 to 24 gram per dl in non-pregnant state. MCV, most reliable predictor of the anemia. The blood group and red cell antibodies are done, which are the blood grouping with help of cross-matching if later emergency arises. Red cell antibodies makes it possible to identify rhesus negative women who are at risk of rhesus immunization. Rhesus negative women are prophylactic NTD administration at 28 to 34 weeks of gestation is done. Coombs test is done, which is direct and indirect. Direct is patient's blood type and RH, and indirect is the presence of any atypical RBCs. Then rubella test is done. It can cause congenital abnormalities in the fetus, especially in first trimester. Rubella vaccination contraindicated in the pregnancy as live attenuated vaccine. Rubella antibodies are present, rules out primary infections during pregnancy, immunization after pregnancy, and avoid pregnancy for 3 months. Then hepatitis B screening is done. HBV screening, surface antibodies if present shows immunity plus no concern. HBV surface antigen antigen, and E antigen shows recent infection or carrier state. Vertical transmission, that is greatest during childhood. Horizontal transmission through contact with bloody fluid, and a baby born HBV carrier, active and passive immunization. HIV is recommended for all pregnant ladies but requires special consent. Screening is done, that is LSR test, assess the presence of detectable HIV antibodies, and definite to test as Western blot test identifies the presence of HIV core and develop antigens. Vertical transmission of HIV from HIV mother can be reduced by 5%, and the use of antiretroviral agent, elective C-section, and avoidance of the breastfeeding is done. Syphilis is done, it is transmitted by vertical method, but if mother is treated with antibodies, it can be prevented. Screening tests are done, which are Venereal Diseases Research Lab and Rapid Plasma Regain, and definitive tests are MHRTP, that is microhemagglutination assay for antibodies to T pallidum, and FTA, that is fluorescent antibody absorption. Hemoglobin studies are done, which are the HB level to rule out hemoglobinopathies. HB electrophoresis is done, which is the routinely performed in women with ethnic origin with high incidence of the hemoglobinopathies. If woman carrier for any of the hemoglobinopathies, the father of the fetus should also be offered testing. If father too is a carrier, there is 1 in 4 chances that offspring will have the disease. Both carrier prenatal diagnosis for the couple is done. In gestational diabetes, as present, not enough evidence is present to support the routine screening for gestational diabetes. More useful is performed at 28 weeks. A random blood sugar, a fasting blood sugar, formal OGTT screening test, OGTT 1 or 50 gram, and definitive test, that is 3 or 100 gram OGTT. Fetal abnormalities are checked, that is gestational diabetes. Okay, we will discuss that in gestational diabetes topic. Okay, so we have discussed the topic of antenatal care, and let's revise what we have learned up till now. Okay, first of all, we have discussed its definition, that what is antenatal care. It is the care provided to the woman from the time of conception till the onset of labor in order to get the optimized outcome for the baby and the mother. Then we discuss what are the aims of antenatal care: to prevent, detect, and manage those factors that adversely affect the health of the mother and the baby. Then we are having booking visits. Okay, so the first risk assessment is usually made at the booking visit. First of all, the confirmation of pregnancy is done. Then after that, the booking history is done, and then after that, booking examination and booking investigation is done. Everything that occurs after the confirmation of pregnancy is booking, whether it is history, it is examination, or it is investigation. Then in the booking history, the biodata, the detailed event of the pregnancy, the past obstetrical history, the past gynecological history, the past medical and surgical history, family history, and social history is taken. All of the detail of the patient is written down. Then on beacon examination, accurate measurement of the BP, the abdominal examination, the size of the uterus, the recognition of any abdominal scars indicative of previous surgery, the measurement of height and weight for calculation of BMI, the urine examination, and the pelvic examination of the genital infections is done. Then on booking investigation, FBC is done, which is for anemia, thrombocytopenia, iron deficiency anemia, then blood group and red cell antibodies are done. Okay, then on booking investigations, FBC, blood group, and red cell antibodies are done. The check for rubella is done, for hepatitis B and HIV screening is done, and for syphilis screening is done, and hemoglobin studies is done. Also, the test for gestational diabetes is done, and fetal abnormalities is checked. Now, coming towards the follow-up visits. Okay, now follow-up visits. So, we are having the antenatal visits. कहाँ क्या? Here it is. Okay. Antenatal visits. So minimum number of antenatal visits are every 4 weeks. And in 20 to 32 weeks, the patient should visit every 4 weeks. Then 32 to 36 weeks, fortnightly visit should done, and greater than 36 weeks, then weekly visit should done. According to Royal College of Obstetricians and Gynecologists, minimum visits are 5. That is at 12 weeks, at 20 weeks, at 28 to 32 weeks, at 36 weeks, and 40 to 41 weeks. Now the content of follow-up visit is: in early third trimester, the following should be carried out: that is blood pressure, urinalysis, fundal height measurement, inquiry about maternal well-being and fetal activity, inquiry regarding fetal movement, that is 24 weeks. Then FBC and antibody screen is repeated at 28 to 36 weeks of gestation. Then rhesus negative women are given NTD prophylaxis, and from 36 weeks onwards, fetal presentation, fetal lie engagement, fetal growth. Now, the final routine visit between 40 to 41 weeks is done. It includes the discussion or induction of labor, and women are advised that delivery should occur by 42 weeks. Women who wish to avoid induction then discuss the pregnancy complications. Okay, so we have discussed the antenatal care. Then after antenatal care, we have discussed the follow-up visits, which are the antenatal visits, and then the content of follow-up visits, and then we have discussed the final routine visits between 40 to 41 weeks and the women who wish to avoid induction. Okay, now we will be discussing the fetal well-being. So we are having for fetal well-being, we will do the ultrasound, the CTC, the biophysical profile, and the amniocentesis. We are having a scenario that there is a PG woman present at 41 weeks gestation to antenatal clinic. Different methods of fetal monitoring during pregnancy, and which is reactive and what is CTG. So we will discuss the different methods for the fetal monitoring. The first one is CTG. It is defined as baseline heart rate of the 110 to 150 beats per minute and a baseline variability exceeding 10 beats per minute with more than one acceleration seen on 20 to 30 minutes CTG. CTG is a technical means of recording the fetal heartbeat during pregnancy. The components of CTG are baseline heart rate, that is for 10 to 5 to 10 minutes, and it should be 110 to 150 beats per minute. Then baseline variability, which is beat to beat variation 10 to 25 beats per minute, and then acceleration, there is increase about 15 beats per minute in baseline fetal rate in about 15 seconds. Then deceleration is checked, that is a transient reduction in fetal heartbeat of more than 25 beats per minute lasting for more than 15 seconds. Okay, so hypoxia is checked and cord compression is checked. Then the biophysical profile of the fetus. On ultrasound scan for 30 minutes, biophysical profile is checked and done to determine the fetal well-being and done for high-risk pregnancies. The 5 parameters are amount of the licle is checked, the gross body movement of the body is checked, the breathing movement is checked, the tone of the body is checked, and acceleration in the fetal heart rate is checked. Now, scoring 4 or less danger delivery is indicated. If it is 6, then borderline and require assessment. If it is 8 to 10, then the biophysical profile is normal. So it can be remembered by TABAG, that is amount of liquor, and the T for tone of the body, A is for amount of liquor, B is breathing movements, and A is acceleration in fetal heart rate, and G is gross body movement of the baby. So we have discussed the fetal well-being, that what investigations are done. These are the CTG and the biophysical profile, and in ultrasound and CTG, biophysical profile, and amniocentesis is done. Okay, now in the next section we will discuss the importance of ultrasound in obstetrics. Okay, now the importance of ultrasound in obstetrics. So we are having a scenario that there is a G3P2 18 weeks pregnant asking for ultrasound, and what are the informations given to the patient, and what are important investigations that can be done under ultrasound guidance. Okay, there is a 18 weeks pregnant lady, and she is she has come for ultrasound. So what are the important investigations that can find on ultrasound? So we will discuss the importance of ultrasound. That is, it shows us a diagnosis and the confirmation of the early pregnancy. Then what is the importance of ultrasound? It shows the diagnosis and the confirmation of early pregnancy, and it tells about the gestational sake, that is 4 to 5 weeks, and fetal heart rate up to 6 weeks. The gestational sake is obvious on ultrasound after 4 to 5 weeks of gestation, and fetal heart rate after 6 weeks. The diagnosis of disorders of early pregnancy can be find out through the ultrasound. Then it shows us the lighted ovum, that is sac and placenta grows but not the baby. Okay, miscarriage or no fetal activity can be seen on the ultrasound, and the determination of gestational age and assessment of fetal size and growth, crown rump length up to head circumference up to 20 weeks, and biparietal diameter can be seen on the ultrasound. And it shows us the multiple pregnancy, which is maybe monochorionic, that is 2 layers of the amnion, and dichorionic, that is 2 layers of the amnion plus 2 chorion. Then the diagnosis of the fetal abnormality, which is spina bifida, hydrocephalus, abdominal wall defect, and cleft palate. Then it shows up at us about the placental localization, that is on 20th week, and amniotic fluid assessment, that is decreased amniotic fluid, the failure of production of renal agenesis, and the increased amniotic fluid, that is congenital abnormality, encephalin and esophageal hernia. And it shows us the assessment of the fetal well-being, the cervical length if short, delivered after 34 weeks. Other uses are the confirmation of intrauterine death and the diagnosis of pelvic and fetal abnormalities during the pregnancy. So we have discussed the importance of ultrasound, that for what it is important. It gives us the diagnosis and the complications, confirmation of the pregnancy. Then it gives us the diagnosis of the disorder of early pregnancy. Then it shows about the lighted on the miscarriages, the determination of gestational age, and the assessment of fetal size and growth. Then it shows us about the multiple pregnancy, the diagnosis of fetal abnormality, the placental localization, and the amniotic fluid assessment. It shows the assessment of the fetal well-being, the cervical length, and gives us other uses, that is the confirmation of intrauterine death or the diagnosis of pelvic and fetal abnormalities during pregnancy. Now in this section we have discussed the following topics, that is antenatal care, fetal well-being, and the importance of ultrasound. In the next section we will discuss about the RH isoimmunization, the labor, the fetal presentation, and the different stages of labor, and the management of labor and pathogram. Thanks for watching.